going on, podcasting world, and welcome back to another episode of the Core Consult RX podcast. And it's episode 53.
53.
Wow.
We have another special guest.
We do.
In our quote-unquote studio.
We were thinking about skipping a guest episode because we had so many guests on recently, but then we were like, well, this is my wife, so we definitely want to have her on.
There you go. So Cole's favorite guest we've had on so far, most likely.
Yeah, definitely top two.
So.
Just kidding.
I don't know. There's been a couple cool dudes on here that have really showed us how much smarter they are than we are.
But today we have PA Anna Swanson.
Boom. Did you almost call her by her maiden name?
Yeah, well, we're in the process of getting it switched, so technically, I guess.
I still call my wife by her maiden name 6 years later.
No way.
By accident. Yeah, I just do it out of habit.
Uh-huh.
So it's all good. No worries. So, Anna, how's life treating you?
Good.
What are you doing these days?
I am doing a fellowship in neurology right now.
Heck yeah.
It's pretty fun.
Yeah? Is it awesome?
It is. I'm seeing patients in follow-up clinic and new patient clinics as well with attending physicians. It's been pretty neat.
That's
Have
awesome.
you enjoyed it?
I have. We've seen some very interesting cases, some interesting migraine cases, along with some cases that you don't really learn about in PA school. So.
Right.
So what's been the hardest part kind of transitioning from student to you're the one kind of steering the ship?
Yeah. So just taking ownership when you go into a patient's room and knowing that, at some point, even though this is a fellowship, I will be the one seeing and treating that patient on my own. Right now, I have an attending that I go out and talk to about the patient after seeing them and examining them. And then we go in and talk to them about a plan. But just transitioning from being like a student to having ownership of the patient's case and their treatment.
Very cool.
Yeah. Did you want to do something in neurology before you started?
I did. Actually, before PA school, I worked in an assisted living facility with patients who had Alzheimer's disease and dementia. So that really interested me in neurology. And then throughout PA school, I did an elective rotation in neurology, and here I am now doing a fellowship in it. So
that's awesome.
Come full circle.
And it's a first-year fellowship for the program, too, so
Oh, is it?
it's cool that you got it.
Yeah, it is.
That's awesome.
Yeah.
How many, are you the only one?
There's 3 of us.
Okay,
including
cool.
myself.
That's
Yeah.
awesome. Are you planning on obviously sticking in that field when you get done? Is there a certain area of neurology that you like, or do you want to kind of see everything?
Yeah, that's a great question. So I love memory clinic. We do that every other Friday, and we see a lot of patients with like Alzheimer's disease or frontotemporal dementia, things like that. So I like the memory clinic that we do, and then I also enjoy general neurology as well. You see lots of different cases in that subspecialty, I guess.
Yeah.
Did you see it's like a spinoff of the SPRINT trial where they are looking at like blood pressure lowering and actually improving outcomes with dementia patients based on blood pressure goals? I think it just came out like a week or so ago, so it's pretty new. I haven't even read it all the way through, but one of our old professors, Dr. Wirt, I ran into him today, and he was all excited to tell me about it, and I was like, I haven't read it, so I was like, I let him down.
Course.
I let him down.
You'll have to send that to me.
I don't know that it's not often that somebody can get the jump on Dr. Wirt on anything.
Yeah.
It's fascinating to me how he gets a hold of this stuff before anybody else in the world does.
Stinks from
no matter how hard you try, he will just come up with something that you hadn't heard about.
Oh,
that came out like 12 hours ago or something.
I always
well,
go,
did you see it? It came out 3 minutes ago, and then
have you not read it?
Right? How have you not heard of this?
Well, my friend ran the study.
Oh my gosh.
That's where
I knew about it 3 months ago.
Yeah, well, he was I was one of the lead investigators. Shoot, I'll never catch him. Yeah, it's awesome to hear. I went to I had a student that was presenting at Grand Rounds that I advised, so I ran into him and got to talk to him a little bit. So it was cool.
Nice.
He gave me like the real quick update on some of the new stuff that like just came out this week. And he's like, "You haven't read all this stuff?" I'm like, "No, sorry."
Did your student nail it under your tutelage?
She did. Well, and that's not me. She did awesome. I just kind of sort of give basic, vague guidance.
Yeah.
No, she did awesome. I was actually really proud of her too because one of the residents tried to
take her down.
And I think he was doing it to see if she would stick with her answer. I don't think he was doing it like maliciously or anything. But I was really worried because she was so nervous going into it. But she did such a good job. I was just hoping she realized she did a good job. So he said, so even with these statements and these guidelines, you'd still treat the patient that way? And she goes, yeah, I would. I was like, boom, sit down, kid. It was awesome. I was super proud of her.
And he literally stood up and he yelled that.
I did. Yeah, that wasn't great. Not professional, but
that got kicked out.
Yeah, I can't go back to Grand Round now.
Oh man.
Yeah, so good job, Meredith, if you're listening. So yeah, she did awesome. That was cool. So how are we going to do this today? We're going to talk migraines.
We're going to do migraines. Another neuro topic, of course. We have our neuro PA in here.
Yeah.
We meant to bring her on for Parkinson's, but we're obviously short-sighted.
You forgot.
Yeah.
Well, that's what happens when you plan the podcast 6 minutes before you start.
Yeah. But so we're doing migraines. It's going to be more of an overview, kind of like our normal overview things. We haven't done one in like 7 episodes probably.
Yeah,
6.
it's been. I miss it. I'm losing like track of where we've done what. But
yeah, it's been because we had guests on, interviewing guests. Love having guests, but I like our overviews.
Heck yeah,
going through stuff, and then soon we'll have some coming out on the new AFib guidelines as well. So another classic guideline episode.
Cool.
Classic
guidelines. Bringing the heat today.
Yeah, we are. Yeah, something like that. We do say so ourselves. So where should we start, PA? You're the provider in the room, so you take the lead, obviously. Where do you want to start?
So we come in on the back end when
once you guys have already done the hard work, we just kind of go, one of these 3 meds would be good.
You guys say, hey, is this okay? And we say, oh yeah, that's okay. Or,
hey, you guys are helpful.
Occasionally, we say no.
We have a pharmacist that works actually with the migraines and multiple sclerosis as well, and she helps us coordinate all the specialty medications.
Is she inpatient or is she in the clinic?
She's in the clinic.
Oh, nice.
Mm-hmm.
That's awesome. How is it with the clinic with you guys? Do the pharmacists, if you have a clinical pharmacist like that with you guys, do you do collaborative practice? Like, do you ever refer them for like, lifestyle management or anything like that to the actual pharmacist, or
not so much? Gotcha. Just with the prior auths and everything that's involved with getting a necessary specialty medication for people that have MS.
Gotcha.
It's quite a lengthy process.
Yeah, I'm sure.
So she has her hands full doing that kind of thing, and recommendations, I would suppose.
Mm-hmm.
Yeah. And that's such a hard, like, specific disease state. Yeah, I mean, that makes sense.
Yeah. Well, cool.
So where should we start?
So maybe we should talk about just the prevalence first.
Yeah.
Let's do it.
So
I know my man Cole has some stats ready.
I got some stats ready. Let's see what you got. What you got, babe?
So migraines are actually most common in women.
Correct.
It's a 3-to-1 ratio, females to males. How prevalent is it in the world?
Yeah, so at least in the U.S., it is more prevalent than I thought. I mean, everybody says they got a migraine, but I figured if you really broke it down, maybe not everybody has migraines, but about 30 million people in the U.S. have one more migraine headache a year, and approximately 2/3, around 75%-ish, are women, but definitely the vast majority. Also, the term migraine is derived from a Greek word, hemicrania. The term was corrupted into like a low Latin word called hemigrania, and then the French translated it to migraine.
Very interesting.
Haven't done word origin in quite some time either.
And you forgot the word origin gong.
Is that what that is?
It's too late, but that's fine. That gong actually symbolizes most things. I just forget what we associate it with.
We just have to put it in before we do the thing.
Yeah.
Yeah. Well, we're not that coordinated.
Next time.
Yeah.
Cool. That's interesting. Where do you find these historical things? Because you always come ready to go with them.
And interwebs, man. Yeah. You never know if they're true. They can make up whatever they want.
But we tell them anyway.
We tell them. It becomes true when you tell them. That's
basically.
I'm
pretty sure that's what Aristotle said.
The important things are cited. The
actual guidelines of medicine are cited. History. We're not historians. What do you want from us?
The word derivatives. I know.
You're getting the stuff for free. Come on.
Come on, guys. But yeah, I mean, a migraine. What is it? It's a complex, recurrent headache disorder that is one of the most common complaints in medicine, whether it ends up being a migraine or not. Extremely common, right? But yeah, there's a lot of causes, and we can go into causes, but frequently, or at least historically, they've been considered a vascular phenomenon. That's come under some scrutiny recently, and there seems to be a little more going on there, but we'll get into that a little more with the patho. So. What do migraine sufferers, what do they usually see? What are some symptoms, some triggers of migraines?
So triggers, the most common triggers I see in clinic are typically emotional stress.
Yeah.
Hormones. There's a lot of catamenial or menses-related migraines. Weather, not eating, sleep disturbances, odors, and neck pain.
Yeah. I guess hormonal contraceptives, can they trigger them, I suppose? I was reading a little bit about that.
They can make them worse. So patients who are migraine sufferers, typically it's not recommended that they're put on a combined oral contraceptive.
Gotcha. And so if they do and then their migraines get worse, you'd probably say, yeah, maybe we're going to take you off that thing.
Exactly.
Yeah. Migraines they frequently have a genetic component. So a lot of people, about 70%, are going to have a first-degree relative with a history of migraine. And like you mentioned with the triggers, there's a lot of environmental and behavioral factors that can precipitate migraine attacks or, at least predispose people to migraines. And we'll list some things as we go and kind of reference them, but there's a lot of strange ones, and it's going to be very patient-specific. But, I mean, from all sorts of random types of foods and smells and things happening outside and allergies and all sorts of stuff can trigger. So, patient will tell you what that is, and you kind of got to work around that. Agreed.
So, can we, Anna, will you walk us through some of the basic patho stuff just so we can understand what a migraine is? You have some of that available, just out of curiosity?
Why don't you take it away, Cole?
Okay, I'll grab it. So, yeah, I mean, there's a few theories. So we talked about the vascular theory, and that's one of the older ones from, the 40s and 50s. It was proposed to explain migraines, but they really didn't have a lot of good imaging and neurologic studies back then. But it was based on either extracranial vessels becoming distended and pulsatile during the migraine attack. They could see that. Stimulation of intracranial vessels while a person was awake that induces a headache, and also vasoconstrictors like ergot derivatives. They would improve headaches. So they kind of went along that line and said, oh, well, if this helps, then maybe this has something to do with it. Whereas vasodilators like nitroglycerin would provoke an attack. But it didn't really explain like prodrome and associated features like that. It didn't explain the efficacy of some drugs that didn't have anything to do with the blood vessels. And so more recently, they've said, okay, there's probably a little more going on than just vascular. So now they have the neurovascular theory, where it's a more complex series of neural and vascular events that initiate the migraine, meaning it's a primarily neurogenic process with secondary changes in cerebral perfusion. So a lot of times a migraineur, or the person having the migraine, has a state of really neuronal hyperexcitability in the cerebral cortex, specifically the occipital cortex. And this has been demonstrated on MRIs, and so that's kind of where they get this theory that it has more going on. So generally, that's how migraine works.
Much more complex than it seems.
Yeah, not as easy as the vasoconstriction, vasodilation, but I mean that's a good way to at least think about it when you're thinking of the mechanism of action of some of these drugs, like triptans and ergots, right? Yeah.
So why don't we talk about diagnostic criteria
for
migraines? I think that's really important. A lot of patients will come into our headache clinics saying that they have migraines when they've never actually been formally diagnosed with migraines.
Yeah.
They just hear through word of mouth that, oh, if you have really, really bad headaches, they must be migraines. Well, that's not the case always.
Yeah, I mean, you hear from the lay person all the time that like, oh, I was having a terrible migraine yesterday, and sometimes they are. And we should say that migraines, as you've seen, are an incredibly debilitating and serious condition. I mean, they can get to the point where people can't hardly leave their house because nothing is helping. So not to take lightly people complaining of migraines, but it's just one of those things that people say when, they might mean something different.
No, they're crippling. Yeah.
Yeah.
So diagnostic criteria. Typically, the pain that patients feel is described as throbbing or pulsating. It can also be described as shooting or stabbing as well. Usually the pain is unilateral, meaning on one side, but sometimes it can also involve both sides of the head. Typically, the pain will last anywhere from 4 hours to 72 hours. Anything after 72 hours is considered status migrainosus. That happens in about less than 1% of people who have migraines.
So that's a 3-day migraine situation.
That's pretty terrible.
It's a bad 3 days.
Yeah.
And has to last the 4 hours, right?
Correct.
So even if you have all these symptoms, but it's only for an hour, then that's technically not a migraine.
Correct.
Okay.
So patients will also either have nausea or vomiting, photophobia or phonophobia, meaning sensitivity to light or sound.
Right.
And then they also have severe pain. We ask them to rate their pain that they experience on 0 to 10, 10 being the worst pain you've ever felt. And usually they rate 7 to 10 plus.
Yeah.
I get that a lot.
Jeez. And, it's interesting because a lot of times if you're asking, is this the worst headache you've ever felt? I mean, if they say yes, a lot of times I guess you work them up for
subarachnoid hemorrhage.
Right. Yeah, that kind of thing, strokes and that sort of thing.
Which is kind of scary. Usually if somebody has the subarachnoid hemorrhage, they say this is the worst headache I've ever had. Right.
So I guess you have to put that on the differential and tease that out between migraines and something more serious.
Depending on the history. If it's acute, if this is the first headache they've had, and they have a history of like mild headaches, yeah. But if it's chronic, then usually we're leaning more towards migraine or some other primary headache syndrome.
Gotcha.
And isn't it, correct me if I'm wrong, but isn't it if you see a person who's never had a history of migraines and now they're presenting as an elderly patient, if that's probably more of a secondary cause, like something like a stroke or something like that?
Typically.
Isn't it normally in the younger patients?
Yeah, typically. Usually it'll present earlier in life. A lot of times in women it'll get better after menopause. Not always, though. And those patients are usually really upset because that's the one thing they look forward to.
Can't wait for menopause.
That's funny.
Yeah. So if somebody's older and they're newly presenting with headaches, severe headaches, migraines, usually neuroimaging is done, whether it be an MRI or CT.
Is neuroimaging like that required if you do suspect it's just a migraine? Do they ever do that just to be on the safe side, or is that just kind of like ruled out?
It depends on the patient's risk factors. Like I had a patient who had polycystic kidney disease, and so we ordered an MRA to make sure she didn't have a brain aneurysm as well. So it really is just dependent on what the patients have and what their history is like as to whether or not we get imaging. But migraines is more of a clinical diagnosis than anything.
Yeah. So it's hard to see on imaging. And doesn't it put you at an increased risk for stroke long term? Is that considered well known or no? I read that somewhere and I don't know. I hadn't heard it a lot, but I figure it kind of makes sense because of the vascular
I think I've read something about it, but I wouldn't stand
Okay.
firm and back it up right now.
All right. Wouldn't
I'll do it. I'm just kidding. So, that's kind of some of the criteria for migraine. And I think like Cole was kind of saying is, a lot of people will take their maybe tension headache that they perceive as being bad, but not compared to what we see in a typical migraine sufferer. So can you, what's some of the differences you would look for like a tension versus a cluster versus a migraine? Like, is there pretty distinguishing factors for those three?
Yeah. So cluster headache typically occurs at night. Usually there's a family history sometimes. It's more commonly in males as well. And that pain is usually excruciating, sharp, feels like an ice pick is being driven into their eyes. You hear that. It's like a buzzword, but in real life.
Ice pick being driven into their eyes. That's a buzzword.
Seriously, I've heard several patients say that, and they do have cluster headaches.
Unpleasant.
Yeah.
It's not ideal.
And
not what you want.
No, not at all. And cluster headaches, they occur frequently. So when you have a bout of attacks, you'll have 1 to 8 attacks a day for about 3 to 16 weeks, and you'll have about 2 of those bouts per year, 1 to 2 bouts per year.
And I guess as opposed to a migraine, which they might say is like unilateral, a cluster, they would say, like, I feel like it's behind this one spot, like behind my eye or something like that.
Correct. And you usually have a lot of other autonomic symptoms as well, like congestion, ptosis, lacrimation, conjunctival injection, things like that kind of help you figure out what headache this patient actually has.
And cluster of like between migraine, tension cluster is really going to be the one that's more common in males, but the other headaches you're going to see more in females.
Correct. But we have seen it in females too, so don't rule it out.
Right, just a little more, just a little more. Cool, interesting.
Yeah, and then tension headaches. Typically, we ask a lot about the patient's background, what's going on in their life, do they work, are they under a lot of stress? A lot of times with tension headaches, or you see tension headaches in patients who are under high stress at work or at home, or aren't getting a lot of sleep and aren't taking care of themselves in terms of mindfulness and just taking care of their body. So we've had to correct a lot of migraine diagnoses before, believe it or not, and actually diagnose patients with tension type headaches.
So I guess that's going to change treatment. That's ultimately why you would want the diagnosis to be more accurate.
Correct. Patients with tension type headaches won't respond to triptans.
Right.
The abortive
normal
therapy
migraine
used.
abortive therapy, which we'll get to soon.
So if someone does seem to be having like tension headaches because of a lot of stress in their lives and things like that, do you normally have to get psych involved at that point too, or can you guys normally kind of just keep it in house?
Yeah, it depends. It depends on what the social stressors are. I actually referred a patient to psychiatry for counseling because she had a lot of stressors in her life. But a lot of times I'll refer them to physical therapy. A lot of times they have neck strain, they have a cervicogenic type headache picture, and they actually do really well with physical therapy and stretching and just taking care of themselves.
That's cool. Interesting.
You like to say frequently that there's a fine line between neurology and psychiatry sometimes too. So
sometimes, yeah.
Yeah, in certain situations. Cool. Yeah, we could do podcasts on tension headache and cluster headache. We could just take on all the headaches.
Those would be really good
headaches.
ones.
Yeah, why not? Just do our headache suite. Our sweet headache
we'll have
suite.
a playlist, if you will.
Yeah. Our headache playlist.
Oh, man.
I've heard some headache playlists, and that was supposed to be a joke about music, but it makes me sound old.
Ha, ha, ha.
Ha ha.
Boom.
So yeah, I think that's generally, so we didn't mention much about aura, but aura is something that you see with migraines as well. The more common migraines are going to be without aura, but it can occur, and you're probably familiar with that. But aura and prodrome, well, those are two separate things, right? Mm-hmm. Yeah, so prodrome is after.
Prodrome's before.
Before, okay, but it's different than aura.
Right. Aura is usually like visual field changes. They see these weird like spots in their vision, things like that. Sometimes they can have numbness in an arm or on a portion of their head. It's really kind of a catch-all sometimes.
Yeah.
There's no clear defined aura.
So it's just something that the patient experienced, and they say, oh, I know I'm going to have a migraine because I experienced this, and you're just going to call that aura, whatever it is.
Exactly.
For the most part.
Usually auras start about 30 minutes before migraines.
I used to have a friend when I was a kid, and if he was going to vomit, he knew because his lips would go like white, like all the blood would drain out of his lips.
Poor thing.
So he basically had a vomit aura.
That's cool.
Yeah.
I wish I had like a, bet the house or be like, now's the time. Strike.
It's coming.
There it is.
It's
and
definitely
full
gonna
house.
Full house.
Yeah, it doesn't work at all.
Oh my gosh.
So yeah, let's talk a little bit about treatment. So generally there's two types. You're going to have your acute treatment, which is going to aim to eliminate or at least prevent the progression of a headache or a migraine if it's happening. And then you have preventative treatments, which are given when the headache isn't actually happening. So you want to reduce the frequency and severity of the migraines and make the acute attacks more responsive to the abortive or acute therapy, right?
Yep.
Yeah. So what are you looking at? What are your first line? If somebody just comes in with a migraine, they've usually probably tried over-the-counter stuff for just headaches generally, right?
Right. Usually they've tried Excedrin migraine or ibuprofen, things like that. But what we usually prescribe are triptans. Those are usually very, very, patients with migraines are usually very responsive to triptans. And there are several of them.
So do you before you get to that point, do you like for patients to try the OTC stuff? Like, do you think Excedrin migraine works, or you just think that's just some Tylenol and junk and might help, but probably won't?
Well, fun fact, actually kind of sad fact, but pregnant women who have migraines, usually they can only take Tylenol for abortive therapy. They can't be on any of the preventative medication that we'll talk about later. They can't really use any of the other abortive medications as well. Not good in pregnancy.
So Tylenol is pretty much the only thing. So if you have chronic migraines and you're planning on getting pregnant, then it's just a tough situation for the most part.
Mm-hmm. They don't even qualify for Botox therapy at that point.
Really?
Yeah.
Really?
Does pregnancy potentially exacerbate migraines or anything?
So usually it should make them better.
Gotcha.
Usually, because there's a hormonal component to migraines, especially in women. So usually it makes it better, but I mean, I have several patients who still have migraines, and we just have to sit there with them and try physical therapy, tell them to keep taking Tylenol, but within the recommended amount, and just plan on treating them afterwards with lactation-friendly medications.
Yeah, migraines aren't really a predictable disease state. It's not like, okay, so we're going to give you this lisinopril, now we're going to increase the dose, and your blood pressure is going to go down. It doesn't really work that way, right?
Yeah. Thankfully, we have a lot in the bag, though, to try with patients.
Yeah, these days, and there's new stuff that we will get to later on as well.
There's new stuff?
There's new stuff.
What?
Yeah. Stabby things.
I don't get it.
Yeah, but triptan, so there are a lot of them. The most common ones, at least I see dispensing, is Imitrex, sumatriptan, also Maxalt, which is rizatriptan. But there's also naratriptan, zolmitriptan, frovatriptan, olmatriptan. I see a good amount of Relpax, which is elatriptan. There's even a sumatriptan mixed with naproxen, which is Trexamet.
It's really cheap, too.
Yeah, I'm sure. It's probably like pennies. Surely it's only brand name as well. But there's also sumatriptan nasal spray for situations where patients are having trouble keeping things down, because I don't think we actually mentioned it, but nausea vomiting is a very common part of migraines, and I think even part of the diagnostic criteria frequently.
It's nausea or vomiting.
Nausea or vomiting, yes. So we'll talk about it too, but a lot of antiemetics come into play, but that's one place where an intranasal formulation might be helpful, and there's also transdermal sumatriptan formulation, which would also be helpful in that situation as well.
Mm-hmm. So one quick note about the triptans. There are several triptans that have been shown in clinical studies to help prevent or help treat menstrual migraines. So again, sumatriptan, but also Emerge or naratriptan, zolmitriptan, Zomig, or frovatriptan, also known as Frova, are also recommended for menstrual migraines specifically because of their long half-life.
Gotcha.
Mm-hmm. Yeah. So Frova's half-life is about 25 hours, which is great for women with menstrual migraines. And then Emerge is about 5.5 hours.
So a lot shorter, but it still works.
Correct.
Cool.
Has there been, I mean, I've seen a couple on like UpToDate and things like that, but like as far as like comparative studies, is there any like good data you've seen being there that is, cause, I mean, it seems like with that many, other than just looking at the kinetics and how quickly it's going to be absorbed with the half-life, it seems like it'd be hard to kind of choose one. Is it a lot of just what they've tried in the past or what their insurance will cover and all that?
Yeah, just a good clinical feeling of, okay, I think this, because of this medication's half-life or its kinetics, I think it's going to work best in this patient because of these specific reasons.
So what's your go-to triptan if you're going to go with one?
Imitrex.
Yeah.
It's got a lot of different routes of administration. It's usually pretty good.
And I guess it's dispensed so often, hopefully one of the cheaper ones and more likely to be covered by insurance. Yeah. Frequently, which for all you prescribers out there, it's helpful for auditing purposes if as the pharmacist, we know how many headache days they have per month, as well as like, the max dose that you want, even though we know what it's supposed to be. If you put that on the script, it's very helpful.
That's good to know.
That way insurance doesn't bug us about stuff.
Cole literally will not give you your medicine unless you bring your headache journal.
I need to see all the headaches.
Give me your headache journal. I will document it. I know. I try to tell him. He doesn't listen. He's a bully.
Mike's just like, everybody have meds.
Yeah.
Give them to everybody.
To fight the insurance companies.
So some other abortive medications that can be used as well. We see a lot of patients on Fioricet. Migraine as well. I don't know if I'm saying that correctly. Actually, a lot of pharmacies don't carry that medication anymore.
Yeah, I haven't seen that one in quite a while. I remember when I was younger, like when I was like 18, 19, 20, like when I was a technician still before, undergrad stuff.
Yeah.
I remember seeing that quite a bit.
Was that the one? That wasn't the one that went off the market then came back on,
was it? Yeah.
Okay, yeah.
Because Migraine they took off the market for a little bit, and it's back now.
Because they took something out of it or something.
Yeah, I very rarely see it.
I thought it was like giving people like heart attacks or strokes or something like that. I can't remember. Don't quote me on that. But it was definitely taken off, I thought, in the early 2000s. But I guess that would have been before Mike's time. So maybe it wasn't then.
Maybe not.
Maybe not.
Never know.
Yeah, so that's an option. So you see NSAIDs a lot. I mean, you're like, yeah, do you recommend keeping over-the-counter stuff on board while you're doing triptans, or do you say, let's kind of focus on the sole migraine meds?
If they respond to it, yes, as long as they're not overusing it. We'll talk a little later about medication overuse headache.
Yeah.
That can be pretty complicated when a patient comes in with migraines and medication overuse headache, and trying to kind of parse out which is which and how to best treat them and how many migraines are they actually having a month and how many are related to medication overuse.
Yeah, don't you have to almost like wean them off of the medication again?
It's pretty terrible. Yeah.
Jeez.
You have to tell them to basically just stop, and you're going to have a rebound headache for like 4 to 9 days.
Jeez.
It's going to get worse before it gets better.
Yeah. And that's something I was not familiar with at all. Medication overuse headaches.
Yeah.
But I feel like since you started working, I hear about that all the time.
Is it pretty common to have people come in that have been just self-treating like crazy?
Yeah. Yeah, unfortunately, I had one patient who was taking 36 Tylenol a week.
Jeez.
Bye-bye liver.
I know. That's what I told her. I said, we need to cut back on that a little bit.
Wow.
But yeah, medication overuse headaches. Typically, the headache will be present for more than 15 days per month. Usually, you have to overuse the medication for more than 3 months for it to technically qualify as a medication overuse headache.
Yeah.
So simple analgesics you have to use for more than 15 days a month for more than 3 months. But things like opioids or triptans or combination medications you have to use for more than 10 days per month for more than 3 months.
Really?
It's kind of technical.
Yeah. But I mean, you have to put words and rules to things so you can diagnose it.
You're right.
And put that on the paper. Words and rules.
Words and rules.
Words and rules.
So we always say on this podcast.
We're very eloquent. Have you ever noticed?
Extremely.
We have broad vocabularies.
I know 17 words.
I had a technician, I think she was from the north, tell me that I didn't have a thick southern accent, and I was very appreciative of that.
That's good to know.
I don't know if it's true. All you people in California that listen, which we have a huge following in California.
Really?
I know, it's weird.
Tell us how hick-like we sound.
Oh, I hope not too much.
Oh,
I don't
sure
think
we do.
so.
You don't think?
No.
Well, we had, what was his name? Tall guy? Man, I can't remember his name. Photographer. One of your students.
Blake. Oh, yeah. Well, that's a completely, Poor Valakia's accent's real thick.
He's got a little twang.
No, for sure. Well, see, I think that people who don't live around South Carolina, they think that we all just sound like that.
Yeah, I think they do.
Realize that, like, in different areas.
Well, we've talked about this. I've talked about what were they, hookworms?
Yeah.
Yeah, I've talked about that. Yeah. They gave us the association with Southerners being dumb. I'll tell you about it later. It's in episode blah, blah, blah back in the day. I talked about it at some point. Anyways.
You don't want to miss it.
No, apparently
you
not.
definitely want to tune in for that. But yeah, there's other migraine meds. There's older ones, ergot derivatives. I was like, hey, Anna, do you guys ever prescribe this? You're like, no, we don't use this. But they are out there, and I think they're kind of the originals. They are supposed to act by counteracting the dilation of the extracranial arteries and arterioles, so they act almost purely on that vascular theory of migraines. But there's ergotamine, dihydroergotamine, which sounds a little more common.
So that one, actually, the spray is FDA indicated for migraines, but the other two forms.
I haven't seen it dispensed. Have you seen it? No, so I doubt it's used often, but it's out there. It's out there.
I mean, is there a reason, like the ergotamines, is there a reason where you would that would be your go-to for a certain type of patient, or just if other therapies have failed, you just give that one a shot?
Yeah, I guess if other therapies have failed, but we have so many good medications that work in patients, I've never prescribed it.
Gotcha.
Yeah. I guess now with the new stuff, you would go to the new stuff as your fallback as opposed to that. So
yeah.
Isn't ergot was one of the reasons for the Salem witch trials and all that?
They do associate. What are they called? They call
moldy bread or something.
Yeah, they call it like a mass hysteria, and they think it was brought on by like ergot poisoning. Yeah. Oops. A lot of witches died back then.
That's terrible.
Yeah, and they were just like, huh.
Oh, here, I just looked it up. So
thanks, Google.
Toxic. Do not consult Dr. Google. Everybody that's listening, that is very frustrating.
I do it all the time.
So toxicologists know that eating ergot-contaminated foods leads to a convulsive disorder characterized by violent muscle spasms, vomiting, delusions, and hallucinations. So
including thinking the next door neighbor
Is a
who's
witch.
just trying
Is a
to
witch.
plant stuff in her garden is a witch. Jeez.
Yeah.
It's crazy.
Her got poisoned.
I'd be so angry.
I know.
Oh.
If you were the witch.
Yeah. I'd be like, dude, really? Like,
Seriously?
you just ate some moldy bread because you didn't want to go to the store.
You're
and
tripping
now,
out. Now I
and
got to
now-
burn at the
yeah,
stake.
That's ridiculous.
Fun fact: LSD is a derivative of ergot.
That makes sense.
That sounds familiar. I think I
Yeah.
knew that. Cool.
Don't do that one, guys. That doesn't help with headaches, I don't think. Maybe it does.
Yeah.
The research isn't there.
I think they're actually studying it for depression in PTSD.
There's a lot of stuff like
Oh, really?
psilocybin and
Military
stuff like that.
guys, yeah.
Mm-hmm.
Interesting. I think there was a grand rounds on that. Anyways, other meds. So Tylenol, obviously, there's like 1,200 brand names for it, and it's mixed in all sorts of things. But people frequently use that over the counter. I even have like opioids mentioned, but like you don't use
Yeah.
opioids for migraines.
Stay far, far away
I
from opioids.
I think these
and
days,
barbiturates.
Yeah, I think these days we're going to kind of stay away from those.
Yeah, the Furanol,
I was
Furacet,
gonna
all
say-
those. Like, I feel like people end up taking 8 a day.
Yeah.
And it's
Yeah.
like, I'm just preventing my migraine.
Usually, patients come to us on it. They've been tried on it
was
by
gonna
their
say,
primary care provider, and
I
we
s-
usually slowly take them off.
I see it a lot, and I feel like that should be used for tension headaches more. Is it?
Maybe.
Or, okay, maybe it's for
haven't used it in
migraines.
particular.
But yeah, we see that a lot. And, but it
Not
doesn't all
great.
it doesn't all have codeine. I mean, you can have it without the codeine portion.
I mean, yeah, but what fun is that?
Yeah, no fun.
You're going to want a little...
Fioricet doesn't have it.
Yeah.
Yeah.
Right. People talk about aspirin, but probably don't want to recommend that either for various reasons. But the NSAIDs generally, and sometimes they'll use Tylenol number 3. Again, more codeine, but we tend to want to stay away from those.
Have you seen anything with ketamine? I've heard that there's been a few like small groups that are looking at ketamine instead of opioids to like dosing it very like infrequently and seeing if it reduces. I think there's actually a clinic in Charleston that's looking at that.
Fascinating.
Yeah, I didn't know if there's anything, if that's like been talked about at all, or if that's just something people are giving that a shot.
Yeah, no, we haven't really talked about it, but that's fascinating.
Yeah, I'll have to look into that because I feel like I keep hearing more and more about ketamine lately. Which
Hear about ketamine for a lot of things.
Yeah.
It's like I think that it is coming about because of the opioid issues.
crisis,
So
yeah.
they're trying to find alternatives for.
So why not give Special K?
Right. Yeah. Special K.
That's probably a better option. I think it probably does in some areas have better characteristics of less likelihood of addiction and things because you're not taking it by yourself on your own.
Yeah.
So I guess those are the main ones before we get to some of the backup stuff, right?
Yeah.
As far as abortive therapies go. And we're kind of mixing some preventative stuff with the abortive stuff as well.
What about caffeine? So I mean,
goodies.
That, or even just like with the caffeine that's in Excedrin and stuff. I mean, is caffeine pretty effective as far as a non therapy, so to speak? Does it seem to be actually something? Because I mean, you'll see like the Excedrin, one of them is migraine, one of them is tension, and they're the exact same thing. It's just different colored boxes.
See, I always thought it was kind of phooey because I always figured that you're having a headache because you're withdrawing from caffeine.
Because you really need that caffeine.
But I think the pathophys idea behind it is that it increases absorption in the gut of the actual drugs. Not totally sure how that happens, but that's the theory. So I don't know if it. I mean, do you see it work for people?
Oh yeah, I mean people use medications with caffeine in it a lot.
Well, in the South, so I wonder what it's like in different parts of the country. But we have like an addiction to goodies powder, and it's actually goodie. It's not goodies. But I mean, there's, or maybe it is goodies. I don't know.
I
But
typed it out as goodies.
yeah, well, there's people who are like, yeah, I mean, I got to take a goodies powder every morning, or I'm gonna just have a terrible headache. And I'm like, it's because you're taking like 1 million milligrams of caffeine.
A million.
1 million milligrams of caffeine.
A ton of milligrams.
Surprising they're alive.
And you're probably gonna have a brain bleed because it's like 600 milligrams of aspirin every morning as well. But yeah.
And the just the healthiest blood vessels.
Yeah, down in the South, people love their goodies. They snort that stuff.
They do. I don't even think they associate that with medicine because they act like goodies is some kind of special magic. I'm like, it's just aspirin.
Yeah.
Like, what are you
Aspirin,
talking
caffeine.
about? Just smash up aspirin, eat that. No, it's goodies, man. That's where it's at.
Goodies is cooler.
I've
You
had
get to
so
mix
many
it in.
people tell me that.
Yeah.
I'm like, okay.
They love it.
Give them, what's those sweet tarts? Smash those bad boys up. There you go.
Same effect.
Here's some green goodies.
It burns.
See, that's the main stuff for abortive. So why don't we talk about some of the preventative things? Some of these random stuff I thought was was interesting because I didn't really think they worked. But I mean, you use things like Topamax and Elavil, and what are some options?
So preventative therapy is huge. First, I think it's important to kind of talk about who meets criteria for preventative therapy. There actually isn't specific criteria for preventative therapy and initiating it. But if a patient has frequent, severe, disabling attacks, long-lasting attacks, or predictable attacks like a menstrual migraine, then they definitely qualify for preventative therapy. It's kind of a case-by-case scenario. So there are several different classes of medication that we use for preventative therapy. There's antihypertensives, there's antidepressants, antiepileptics, and then some herbal supplements, vitamins, and minerals. Most commonly, I think I use topiramate and propranolol and Elavil mostly in clinic.
That's what I hear of the most too, as far as if you're going for something to prevent.
So beta blockers are typically used more than like calcium channel blockers or ACEs or ARBs, which are sometimes used for migraine prevention. But it's important to remember that any beta blocker, it can't be used in women who are planning on becoming pregnant. That's dangerous. Also, if they have asthma, because of that beta action, you don't want to prescribe it to those patients either. And then you also need to look at their pulse and their blood pressure. I mean, if their pulse is 52, you don't really want to give them a beta blocker. There's several different therapies that you can consider for prophylaxis.
Yeah, so that's beta blockers. So what about Elavil versus like an SNRI, like Cymbalta or something?
Yeah, so most of the evidence, if you're gonna use an antidepressant, is behind Elavil. They recommend venlafaxine as well, but it's very weak evidence. Amitriptyline has been the best one.
Yeah,
we use that a lot also in patients who are post-concussion syndrome. Any patient that has like that 3 to 1 year long headache, just not good functioning. You put them on amitriptyline for that as well.
Yeah. And what's your major rate limiting step that you see for Topamax?
Side effects, for sure. I had some patients that responded really well to Topamax, but the numbness and tingling around the mouth, the mental cloudiness, the tingling in their fingers, they just could not tolerate.
So I mean, the Topamax is just a real thing.
Yeah.
People,
it
dumbs
is.
You out.
And this was a healthcare professional. She's like, I can't be like this at my job. You know, I've got to be able to think quickly and sharply. But otherwise, it worked well. It decreased her migraine frequency from like 8 a month to 1.
Really?
Yeah.
So maybe if like you had a patient that had migraines and also, or you needed to prevent, but also maybe weight loss, then Topamax is a good option.
Exactly.
Or if they were like super, super smart, and then
you needed to bring them down to your level.
Just they could handle the Dopamax.
That's a good
And then they're just like a normal person.
You need every edge you can get.
Yeah, so maybe they should start giving IQ tests before Topamax.
Ben, watch your food. Cole might be giving you some Dopamax.
Oh, okay, so he's just that much smarter than me now.
First of all, Ben is only slightly smart. How's Ben doing?
He's good. Yeah,
Good.
He's having a baby actually.
Is he? Good for him.
And like, I can't remember when. April?
No. July.
Oh, okay.
Same thing.
I was close.
That's basically April.
Mid-year sometime.
Yeah.
Yeah, but he was on episode so-and-so back in the day. But he's been in here before, too. So this is my second family member we've gotten on the podcast.
Woohoo.
When's your mom coming to talk?
No.
Dad, anybody else want to talk?
Oh, your dad would love to be on this.
Oh, yeah. Well, he'll come and talk about, I can't even talk about what he does because it's secret for the government.
Oh, nice.
Yeah.
Let's definitely get him on here.
Keep that going.
He works at Area 51, just in case anyone's wondering.
He's out in Nevada all the time.
That'd be so awesome.
Or Nevada. Apparently they say Nevada if you're from there.
Oh, please.
I know.
Changing words. Anyways.
So other stuff. So people use gabapentin. People use Depakote. Do those work?
Yeah, they do. Depakote is something that we'll consider when we're kind of on the cusp of classifying someone as a chronic migraine and trying to get them qualified for Botox therapy. Usually they have to try Depakote as well.
Gotcha.
But if they're a woman of childbearing age and they're not on emphasis on the effective contraception, then they can't be put on Depakote.
Yeah. I mean, I would be hesitant. I'd consider it dangerous for any woman of childbearing age to be on it.
Mm-hmm. Topiramate as well, right? So also category X.
And that can't that decrease the effectiveness of birth control?
Topiramate?
Yeah.
I think there is some sort of a CYP interaction.
Yeah.
But yeah, I think topiramate can actually cause birth defects.
Yeah.
So
it can also cause acute angle closure glaucoma. So you got to watch out for that, and you got to tell patients about that if you're starting them on that therapy.
What a random, unfortunate thing to happen.
And kidney stones.
Yeah.
Make sure they're drinking a lot of water.
Yeah.
But topiramate is FDA approved for migraine preventative therapy. Usually we'll titrate patients up to 100 milligrams over 4 weeks, and usually we see effectiveness at that dose, but they can be on anywhere from 25 to 200 milligrams to see effectiveness in therapy.
And gabapentin, I feel like it can be used for literally anything now. But migraine prevention. So you see that work occasionally if you're trying to, not a last-ditch effort, but some other things.
Absolutely. I mean, and it's great if a patient also has like a radiculopathy, or if they have seizures and migraines. These anti-epileptics are wonderful to put patients on.
Interesting.
Is there ever a case where you would put somebody on like 2 different prophylaxis, or do you typically keep one agent and then if that doesn't work, switch to a different one?
So a lot of times you can start out with one agent, and if they have some benefit, but not a lot, you can look at starting another class of medication. I haven't done that so much. I've had some patients come to me on 200 milligrams of Topamax, and their migraines still aren't well controlled, but the patient does not want to stop the Topamax because they had some improvement with it. So then we'll start them on like Elavil or like propranolol or something to see if there's any other benefit. But definitely one at a time to see which medication is working.
Right. Cool.
Makes sense.
So those are some other preventative therapies.
Another interesting therapy that has been shown to be effective. A lot of people talk about like magnesium or riboflavin or coenzyme Q or feverfew as being effective. And there is some evidence that helps. But butterbur is another herbal supplement, I guess.
Butterbeer?
If only. No, but butterbur is
That's
level
a Harry Potter
A.
reference, Mike.
Yeah.
Is it?
Yeah. Mike doesn't ever get my TV references.
Do you know Harry Potter?
Yeah.
Do you know Daniel Radcliffe?
Do you know him? No, he doesn't know him.
Yeah.
Do you know who he
called
is,
me
though?
That's the dude that plays Harry Potter, right?
So you would be appalled
Yeah.
if you didn't know.
Oh, man.
I know.
I'm a
If you didn't know.
hardcore Harry Potter fan.
Cole, why would you call me out in the middle of the podcast?
I know. Well, we went to Universal Studios in Harry Potter World. Dude, it was awesome.
So I've never sat through a single second of Harry Potter ever, and I still thought it was awesome just because I was like, this place looks super cool.
No, it was great.
We need to have you and Jen over to watch some Harry Potter.
Yeah, you gotta watch the Harry Potter movies, man.
Yeah, we'll be right there.
Anyways,
I like that you guys like it.
Thanks.
back to the butterbeer.
So butterbur is a level A prophylactic
Is it
therapy.
really? Level A.
Yeah, so level A by the American Headache Society and American Academy of Neurology, their 2012 guidelines say that Depakote, anywhere from 400 to 1,000 milligrams a day, metoprolol 47.5 to 200 milligrams a day, propranolol, like we talked about, timolol, topiramate, and butterbur are all on that list.
Is that over the counter?
Yes.
Interesting. Never seen it.
Butterbur.
Butterbur.
It's good for patients.
Sounds delicious.
It does.
Right. It's good for patients who want more of a homeopathic approach.
Yeah, they want to give that a shot.
Yeah.
For those
I prefer my medications to work, but that's just me.
I heard one
Just
farm.
kidding. I had to say it. I make somebody who's listening mad. They do work. My essential oils are amazing. I just lost like 3 followers for just that. No, sorry, guys.
Boom, just now.
Boom, just now.
Making
I
fun
had
of
to.
essential
I was like,
oils.
don't say it. I was like, yeah, say it.
I had to say it. No filter. So cool. Yeah. So that's some preventative therapies. So
Yeah.
a couple of other really cool ones that I'm interested in talking about are the new injectables, as well as Botox. I really did not think that was
Yeah.
used as much as it's used.
Oh, it's used a lot.
Yeah.
A lot. We have an attending who all she does on Friday is Botox.
Really? She actually, does she administer or does she just work people up for it?
Oh, no, she administers it.
Oh, really?
It's 31 injection sites.
See, I had this in my mind that you go to some like spa, but you just
Puffer official of the wall.
No.
you bring your prescription though, and you just hand it to them.
Spa.
Come from a Botox.
It's more of a Greek bath.
Oh my gosh. No, it's far from that.
Yeah. I've actually heard several people, though, that said that when they switched over and were getting Botox treatments, that it was completely took the migraines away.
That's great.
We dispense it from the pharmacy one time.
Do you?
For injection, yeah. It's just like
take it back to the clinic?
Yeah. Yeah.
Yeah, so we can talk about that if you guys want to.
Yeah. So when do you use it? Why do you use it is it just last ditch effort when other things aren't working, or is there some time where you might say, yeah, you're going to be good for Botox before we try all this other stuff?
Yeah. So actually, Botox therapy is only approved for chronic migraine patients.
Okay.
I'm sure you've seen the commercials, plenty of commercials on TV about the new Botox therapy. But for someone to be classified as having a chronic migraine, they have to have 15 migraine days per month. So kind of interesting, and I had to learn this as I was going throughout my fellowship, is that if a patient has 4 quote-unquote migraines a month, those migraines can last anywhere from 4 hours to days.
Right.
And so you'll multiply however many migraine episodes they have by the days, and that's how many migraine days they have per month.
So that's why they say migraine days and not migraine episodes. That makes so much more sense now.
Yeah. So when you think about it that way, a lot of people do qualify for Botox therapy.
So that means that half of their month, so literally half of their life, is spent with a migraine during that day.
A debilitating headache.
It's crazy.
Yeah.
That's terrible.
Yeah.
So they usually have to fail some of the preventative medications we talked about. It depends on their insurance, how many they have to fail. But I typically see if they fail 1 from each class or 2 from one class and then 2 from 2 other separate classes, then usually it'll be approved, which is good.
It's pretty expensive if you were just try to pay for it outright, isn't it?
Yeah.
Like thousands or...
Honestly, I'm not sure. I had one patient who, this is not in South Carolina, but in another state, she had to pay $1,000 on top of her insurance.
Oh my
what her
gosh.
insurance already covered.
Really?
Each time she went.
And it's done every
3 months.
Gotcha.
But it worked for her. So she was willing to pay for it.
$300
Yeah, I mean, I guess
a
if
month.
you're having half your month spent, like that's pretty reasonable. I mean, not reasonable, you know what I mean?
Right.
I would be,
if you had the means, then it's definitely worth it.
Yeah.
Absolutely.
Yeah, so Botox therapy was approved for chronic migraines in 2010. It involves 31 different injection sites, which can be limiting to some patients who are deathly afraid of needles.
Especially because it's in your face.
Right.
Basically.
Right. So they inject above your eyebrows. They inject the frontalis muscle, the temporalis muscle, the occipitalis muscle, behind your head or behind your skull, and then your cervical paraspinal muscles and your trapezius muscle. So it's a lot, but it can be done within 15 minutes.
And I was interested to hear, so how do they decide on those places? They just start sticking people and find out like, oh, so not your kneecap. We're going to want to put this in your head.
So interesting. I actually learned this from my attending. So of course, Botox therapy was originally used for people who want to get rid of wrinkles in their face and to look younger. And so doctors would do this therapy for them, and then the patients would come back months later and said, I look great, but my headaches also got better. And so they started investigating, and I guess because of these sites, and I'm sure they honed it more as they did trials for it, but they realized that these locations were good.
Well, as it turns out, people don't really care about wrinkles on their calves. They care about it on their face. So that was where they were originally stuck. So
no, I definitely don't want wrinkles on my calves.
Yeah, I mean, wrinkly calves. I mean,
Nobody
seriously?
likes that.
Talk about unattractive.
Too
I
funny.
need some Botox pretty soon, probably.
So does this actually help cosmetically too? Is that like a strange side effect of it
Yeah,
all?
it can. We joke with patients that, and you'll get rid of some wrinkles as
There
well.
you go.
It's the best of both worlds.
Fabulous.
That's hilarious.
Yeah, so they have to come in every 3 months to get this done. And usually when we start them on Botox therapy, we'll also keep them on any preventative medication that has worked in the past. And we'll ask them to keep a headache diary so we can really track the progress of the Botox therapy. Sometimes it can take up to 3 sessions before they start seeing improvement in their migraines.
Yeah. And before we finish up with these injectables, I guess we meant to mention the triggers are very important. We talked about triggers, but counseling on trigger avoidance is obviously important. And so keeping a migraine headache diary, like you just mentioned, is important at the initial stages of diagnosis. So you can, especially if people don't know what their triggers are necessarily, I guess trying to help them figure that out.
Yeah, usually they figure out pretty fast.
Yeah, I guess so.
Yeah.
Yeah. Anyways, so new injectables. There's 3. It's Aimovig, Ajovy, and Emgality. That's my best. That's my best shot.
Ajovy.
Ajovy. Okay.
Come on, Cole.
That's okay. Usually he's the one that corrects me on how to pronounce things.
Well, I'm the pharmacist, so whatever I say goes.
Boom.
Oh, it's not just medication.
Oh, is that right? Getting a little feisty.
Calling you out.
I am.
But these are all monoclonal antibodies. We don't have to pronounce those. And Aimovig was the first one, right?
Mm-hmm. Yeah, so Aimovig, it comes in either 70 milligrams or 140 milligrams. It's actually a CRGP receptor antagonist, which the calcitonin gene-related peptide, that's what it stands for, is a trigeminally derived vasoactive peptide. So recently they discovered that, not recently, I guess it's been ongoing for years, that this peptide is involved in migraine initiation. And so they discovered and developed this medication that can affect those ligands or proteins and the receptors that they bind to.
So it just prevents them.
Mm-hmm.
Do you like it? Does it work?
So I've started 2 patients on it.
Okay.
There's not a lot of long-term safety data, so I'm kind of hesitant to start patients on it. But if they've failed everything and our hands are just tied, I'll start them on it. But some patients are really receptive to it. And I think I'm becoming more accustomed. Remember, I'm a young PA, so I'm kind of hesitant to prescribe certain medications.
Nonsense.
Yeah.
Just got to go for it.
Yeah.
Buyer beware.
You just got to go for it.
No, I am much more conservative.
So do you have concerns with side effects? Anything in particular? Or?
No, not really. The most common side effects are just injection site reactions. With Aimovig, they also had constipation, but all the other ones, the most common side effect was the injection site reactions.
And this one's a once a month injection.
Correct. So Aimovig, it's a CGRP receptor antagonist. It's a monthly injection in either the abdomen, upper arms, or the thigh as well. And at 4 to 6 months, just in trials, they saw a decrease of about 3 migraine days per month. And at the beginning of those trials, their mean migraines were 8. So
Okay. Almost in half.
Yeah, almost in half. So you'd probably use it in combination with other preventative medications as well. A lot of times we'll add it to Botox therapy.
Gotcha. And then the other 2, they're pretty similar, basically the same. So would you really go with Aimovig for the most part, or is there a time when you would try to use one of these?
Yeah,
2?
So that's where our, I guess, clinic pharmacist, did I say
Clinical
that correctly?
pharmacist,
Clinical pharmacist, that's where she comes in handy. Whenever we see patients in the same building that she's located in, we can actually send the patients to her at the end of the visit. She'll show them all of these different medications and demonstrate that to them, and then they can decide which one they want because they're all pretty much the same.
Yeah, and I guess it depends on whether she thinks she'll be able to get it covered or give them some type of copay assist or trial period, something like that.
Right, which, yeah, exactly. The only thing that is patients are kind of hesitant about is Ajovy is a syringe.
Right, as opposed to an auto-injector type thing.
Exactly. And they actually came out last, so that was interesting that they didn't change their administration route because Emgality, I don't know if I'm saying that correctly, and Aimovig are both auto-injectors.
Gotcha.
I think it's a similar autoinjector to like the Repatha Praluent, isn't it?
Yeah, PCSK9s.
And I was actually reading something today from Journal Watch Neurology that was talking about Aimovig. I guess was the results of everybody kind of quotes from that was actually the phase 2 trials. Yeah. And that the other 2 are the only ones that actually have solid like phase 3 with chronic migraine. So I thought that was kind of interesting that the other one still was published first or approved first and all that. But there's an article in Journal Watch talking about I think it's titled which anti-CGRP antibody to choose first for chronic migraine. And so it's a quick comparison.
What did they think, or did they just compare them?
The other 2, besides Aimovig, they were saying the benefits were kind of negligible as far as which one's better than the other. But his point was, I'll quote him here, that Aimovig showed an impressive result of mean reduction of 6.6 days per month. It was tested only in phase 2 clinical trials for chronic migraine in the Lancet Neurology 2017. Comparing phase 3 trial data with the other two did slightly better. At reducing headache, galcanezumab did slightly better at reducing headaches.
Emgality is the gal.
But the difference is negligible, so not clinically significant.
Okay.
Cool.
So, yeah, that's interesting.
Yeah.
I feel bad for ragging on Ajovi. So one benefit to it is that you can...
I don't feel bad for those guys. I'm sure they're making plenty of money still.
Yeah, they could have come up with a better name, too, that was easier for me to pronounce.
Fremanezumab? I mean,
I
seriously?
know, that's a mouthful.
That's showing off.
Yeah, they're just showing off. They had to be the longest name. They had to have the most letters. Kind of like Mike behind his name.
Jerks.
So its dosing is usually 225 milligrams, but you can load the dose and do 675 milligrams every 3 months instead of monthly like the other medications. But you also have the option to do just the 225 a month each month.
So that's where they get you, that 3-month thing.
Yeah, if you're willing to inject yourself
That's
with
the
a
selling
syringe.
point.
Yeah.
That's pretty cool. So we'll, I guess, is there anything else really to go in depth with that stuff? That's kind of the new. There's another one, the fourth one in that class, I think, is scheduled for 2020.
Really?
Yeah.
So I'm sure you guys can hear my dogs barking. They wait till the last episode, or the last couple minutes.
Well, at least they were polite and waited till the end.
I'm just going to go ahead and call it out like it is, because I know you guys are like, what is that noise?
The dogs are basically a part of the podcast.
Yeah,
they're as much a part of the podcast as Steve is.
Yeah, that's true. Well, actually, Pete, remember when Steve is gone, because we got Pete now, and Pete's still in Germany.
Is he still?
He's still in Germany.
He was in Germany last episode.
Supposed to be here filming our podcast, and he said he's working on robots in Germany.
Well, that's cool.
Yeah,
cool.
Let's not get carried away.
So
our podcast is probably as cool, if not better.
So he needs to bring a robot back that we can incorporate into the podcast.
Oh my gosh, could you imagine?
Need to add it to the wall.
Yeah,
I do.
Create a new ledge.
If he doesn't come back with a robot, he's done. He's fired.
Over. We're getting a new Pete.
Yes, I just need to find another engineer who's willing to work for free. That's like a dime a dozen, right?
Yeah, they're all over the place.
Oh, man. Well, Anna, thank you so much for taking the time to come out and talk to us. I know we said it was going to be a 20-minute podcast, and we kept you here over an hour. That's how we do it. We lull you into a full sense of security.
That was good. That was a good migraine overview. We'll take on the other headaches later on.
Thanks for having me.
Absolutely. I think this is good because what we'll do is we'll stick with these, like, real kind of basic overviews, and then that gives us the whole, like, let's go deeper the next time around when we run out of topics.
Once we're at episode 500, we'll finally be able to go deep into the topics.
Finally.
Yeah, finally.
So the world holds its breath. Cool. Well, thank you guys so much for listening. Thank you guys for the support. I really appreciate the ratings, the comments we've gotten, the emails. Those really do mean a lot to us. So, anything we can do to improve, we are all ears. We definitely want to keep the show getting better and better. So we are always looking for feedback and pointers. And if you guys do like the podcast, make sure you subscribe, leave a comment, and we will catch you guys next time. See ya.